Hi, Dr. Ramesh. Am I audible? Hello, Dr. Ramesh. Am I audible?
Loud and clear, sir.
Good morning, sir. Yes, sir.
Yeah,
morning,
good
sir.
morning, good morning. Good morning, Dr. Madhur. Ramesh, did you talk to Dr. Russell?
No, sir. Veda is said she'll be joining, sir.
Okay. So did she confirm that Dr. Russell will be joining now?
Yes, sir. Yes, sir. She's confirmed, sir.
Okay. Can you just message him, somebody?
Yes, sir.
Or maybe just talk to him on WhatsApp.
Morning, Amit sir.
Yeah, good morning.
Morning.
Am I audible, Mahaveer?
Yeah, you are audible, sir. Clearly and loud and clear, sir.
Good morning, Mahaveer sir. Dr. Madhur sir.
Dr. Madhur, कैसे हैं?
मैं बहुत बढ़िया हूँ sir. Thank you very much.
And we are waiting for the green signal from the Dr. Ramesh and Amit sir and you, so we can start, sir. Saran is with me, and we are.
So we are just waiting for Dr. Russell to join, sir. Just about 2.
Okay.
Just a second.
Hi, very good morning. Should we start?
Good morning.
Good morning, sir.
Just waiting for Dr. Russell, sir.
Okay.
Veda is.
I think we can start, and the moment he will join,
Sure, sure, sir.
yeah.
So,
I think Dr.
Yes,
Russell
yes.
just coming. He's just informed me that he is just joining. So if we can wait for about 2 minutes, it's okay. Otherwise, we'll start.
Yeah, we can wait for 2 minutes. Yeah.
so
We'll start at 10:05.
yes, sir.
You can take a stick.
I see Dr. Russell has just joined us. So I think we'll start the session. Good morning, everyone. Season's greetings from Academic Committee of STAT. Myself, Dr. 𝘱𝘰𝘭𝘺𝘵𝘪𝘵. I'm an Associate Trauma Consultant at Ganga Hospital, Coimbatore. I welcome you all for the first TAC Grand Rounds of the STAT Academic Committee. Today we have AIIMS Jodhpur presenting a case on multi-system trauma. Before we go into it, I have two quick announcements. We have Journal of Injury and Acute Care, Journal of the Indian Society of Trauma and Critical Acute Care. So we request all the participants and the faculties to encourage their residents to submit this manuscript. It's a peer-reviewed journal. And this time we are also starting, we are going beyond the TAC Grand Rounds. We are having learned from the master sessions from the academic committee. Please follow the social media and your mails for further updates. So to start with, we have an expert panelist, a great set of panelists for this session. I will first introduce Dr. Amit Gupta sir, who is a professor at AIIMS Trauma Center, JP and Apex Trauma Center. My mentor, my teacher with special interest in trauma research, trauma critical care, and trauma systems. Is also the General Secretary of the Asian Collaboration for Trauma. Over to you, sir.
Thank you, Ramesh. I hope I'm audible to everybody. It's a great pleasure on behalf of the Indian Society for Trauma and Acute Care to welcome my fellow experts for this first TAC round of 2026. I welcome all the participants also. It's my great honor and pleasure to welcome Professor 𝘱𝘰𝘭𝘺𝘵𝘪𝘰𝘯. Professor 𝘱𝘱𝘭𝘺𝘵𝘪𝘰𝘮 is a trauma surgeon, an innovator, an experienced medical leader, and is currently serving as Associate Provost of the Health and Medical Sciences at the Hong Kong University of Science and Technology. He has remained the Dean of the College of Health and Medicine at the Australian National University in Canberra, and has helped establish the new Lee King Kong Chain School of Medicine at the Nanyang Technology University in Singapore as its Vice Dean. Professor 𝘱𝘱𝘭𝘺𝘵𝘪𝘰𝘮 is an avid researcher. He has served as a trauma surgeon at the Alfred, one of the biggest trauma centers in Australia, and also remained the director of the National Trauma Research Institute in Melbourne. He is recognized for improving surgical and trauma care through leadership of international initiatives, clinical trials. He's been a champion of the Asia Pacific Trauma Quality Improvement Program and has been involved in trauma quality improvement all over the world. He is the president of the Australian chapter of the International Society for Surgery and the member of the ISS Council. He is also an elected fellow of the International Society for Surgery, the Australian Academy of Health and Medical Sciences, and the Academy of Medicine of Singapore. Welcome, Professor Russell. Great honor and privilege, and above all, a great friend for a very long time and an avid India lover. Thank you, Russell, for joining in for this first TAC round of 2026. Along with Dr. 𝘱𝘱𝘭𝘺𝘵𝘪𝘰𝘯 is my fellow colleague, Dr. Mahaveer. Dr. Mahaveer is one of our alumnus from the All India Institute of Medical Sciences. He is right now the Associate Professor in the Department of Trauma Surgery and Critical Care at AIIMS 𝘱𝘱𝘭𝘺. Although Dr. Mahaveer has got many feathers to his cap, but one of his feathers is actually the establishment of trauma care systems in the state of Uttarakhand, especially in and around 𝘱𝘱𝘭𝘺. He is the pioneer for starting the first heli-ambulance service, the government-owned heli-ambulance services at AIIMS 𝘱𝘱𝘭𝘺. He is the founder and in charge of the AIIMS 𝘱𝘱𝘭𝘺 Aeromedical Services. He is also the architect and founding member of the first heli medical services program of the country, the project called Sanjeevani. As a course director, he is also a course director of the ATLS India program. He is faculty for many, many courses. He is also on the Road Safety Council of India and on many other committees, national and international. Welcome, Dr. Mahaveer. It's a pleasure having you as an expert.
Thank you very much.
And I will hand over the mantle of the day's program to our moderator, Professor Mahaveer Rodha, who is the in charge professor and head of the trauma surgery department at All India Institute of Medical Sciences at Jodhpur. Dr. Mahaveer, over to you. Dr. Mahaveer is also a faculty of ATLS India. He has more than 60 publications, and he is course in charge of the trauma surgery program at AIIMS Jodhpur. Dr. Mahaveer, over to you.
Thank you, sir, for kind introduction. Good morning. On behalf of the AIIMS Jodhpur Trauma Surgery in Jodhpur, I welcome the panelists and our participants for today's CCR. Straightforward thanks to the staff who gave the opportunity to present something on this academic platform, which is meant for the trauma surgery only. So today, the Dr. Saran, the MCS resident, will present the interesting case. Interesting case, it was a long ICU stay and a long multiple issues, and finally we discharged from the hospital. So this is the some things. This is the one case who teach us and who tested us for the whole system, like the CNS, like thorax, like circulatory, abdomen, GI, ICU care. So one case teach a lot of things us, and he tested our the knowledge for that in that area of care also. So this is the case Dr. Saran will present. As the format of the CGR one, 30 to 40 minutes, where the presenter will finish it. I request the audience, they will post their question in chat box so that they can be taken care of after the presentation. And I request the participants, please keep mute the devices so the interruption can be minimum. Sir, over to you.
Good morning, respected faculties and sir. Thank you for the introduction. I'll be sharing my screen now. Is my screen audible?
Yeah, you're visible. Yeah, it's visible and you're clearly audible. Sorry, okay. Please go ahead.
Okay. Thank you, sir. So I'll be presenting a case of surviving multi-system injuries. So this is basically polytrauma. So polytrauma is basically a disease beyond pure anatomical injuries. It has a lot of physiological risk of deterioration and risk of complications. So this requires a specialist-led care for the competing priorities in polytrauma. So injuries of two or more different anatomical regions with one or more additional physiological parameters can be considered for polytrauma, and a ISS score of greater than 15 is frequently used as the definition of polytrauma. Coming over to our interesting index case. So we have a 65-year-old male who presented in the early hours of the 18th of September 2025. He had a road traffic injury. He was on a two-wheeler and unhelmeted. He had a skid and fall and sustained injuries to his head, face, chest, and abdomen. He had a loss of consciousness and ENT bleed, but no seizures and vomiting, and he was brought directly to our center. On primary survey, he had multiple facial lacerations for which pressure dressing was done. His airway was patent and C-spine was stabilized with a Philadelphia collar. His saturation was 94% on room air, respiratory rate was 24. Bilateral air entry was present, however, reduced on the left side with a chest compression test was positive, and high flow oxygen was started. His pulse rate was 91 and BP was 128/60 with a negative pelvic compression test. Two IV large bore cannulas were secured and samples were sent and warm crystalloids were started, and his EFAST was positive in a splenorenal region. His disability, his GCS was E4 V4 M6 and was irritable. Pupils were right side non-reactive to light and left side was reactive. Warm blankets were placed with a warmer and Riles tube Foley's was inserted. His ABG done had shown a base deficit of -3 and a lactate of 2.3, and moving on to the ample was not significant. So after this primary survey with the resuscitation, the patient had multi-regional injury, was a responder with EFAST positive. So we had planned for imaging with an NCCT head with cervical spine screening and a CCT torso. This is the NCCT head showing frontal contusions with the perilesional edema and a sulcal SAH over here. This is the CT of the chest showing that there is a left pneumothorax and a left hemothorax. This is the CT of the abdomen showing a grade 5 splenic injury with active contrast extravasation with pseudoaneurysm and collection in the subdiaphragmatic region. So the patient was diagnosed with a road traffic injury with polytrauma with head injury, rib fractures, left hemopneumothorax and a grade 5 splenic injury. So his ISS was 38 and NISS was 43. However, following the CT, the patient developed hypertension with tachycardia and a BP of 60/40. His ABG done had showed lactic acidosis with a base deficit of -8. So patient was, we had started massive transfusion protocol and shifted the patient to OR. In the OR, a left ICD was placed prior to induction of anesthesia and 200 ml of blood was drained and an exploratory laparotomy was done. Following laparotomy, there was gross hemoperitoneum, a 4-quadrant packing was done. There was a shattered spleen with active bleeding and a splenectomy was done. The rest of the solid organs appeared grossly normal and drains were placed. The patient was transfused with 4 PRBC, 4 FFP and 4 RDP. The patient following this surgery was shifted to trauma ICU where the patient was observed. His GCS was E1 VT M5 and we had started him on anti-edema measures and anti-epileptics, and a repeat CT done had showed no progression or interval change in the head injury. The patient was managed as per BTF guidelines. While in the ICU stay, we had progressively taken X-rays and observed the patient, and the chest X-rays were within normal limits. On post-op date, on day of injury 3, we had started nutrition and DVT prophylaxis. On day of injury 5, due to prolonged mechanical ventilation, the patient had undergone an elective tracheostomy. Following the tracheostomy, patient had developed hypertension. A BP of 170/80 was recorded and we had started him on antihypertensives. He had a fever spike for which cultures were sent and he had a gradual increase in the FiO2 from 30 to 80. His total count started to elevate. His creatinine increased and total bilirubin also gradually increased throughout this stay. So on day of injury 13, he had bilateral crepitations present and an X-ray done showed bilateral opacities. A PF ratio showed PF ratio showed 100, which was indicative of severe ARDS with type 2 respiratory failure. Cultures done had showed crab positive on bronchial culture and a fungal growth on the CVC tip, and patient was started on antibiotics and antifungals as per culture sensitivity report. Following the diagnosis of ARDS, so we had adopted a lung protective strategy, that is a low tidal volume, high PEEP and proning. Proning was done 3 times and was done for a period of 16 hours. We had continued routine ICU care and antibiotics. So these are the serial X-rays done following proning, which had showed gradual resolution of the ARDS. His total count and creatinine also started to resolve. Following this, however, the patient had bilateral crepitations with left lower zone air entry was reduced. On an X-ray, it showed blunting of the costophrenic angle, for which a HRCT was done. It showed a left retained hemothorax, for which a ICD was placed. This is the X-ray showing post-ICD insertion with partial resolution of the collection. However, the patient progressively deteriorated, for which we had done a repeat CT and showed multiloculated retained hemothorax with the collapse of the left lower lobe, for which we had planned a operative intervention. We had initially done a VATS followed by a left posterior lateral thoracotomy. Here, the hemothorax had retained clots, for which was evacuated, and peels over the lung, entire lung were released. And post procedure, the patient had full lung expansion and 2 ICDs were placed. During this operative intervention, the patient had 2 PRBC, 2 FFP, and 2 RDP were transfused, and vitally, patient was within normal limits. However, the patient gradually had tachycardia, a BP of 100 systolic, with an ICD output that was hemorrhagic of around 800 ml. HB was 8.2, and there was decreased hematocrit, for which an MTP was activated, tranexamic acid was started, and patient was shifted to the OT. During re-exploration, it was found that the patient had a bleed from the intercostal vessels. So following this, hemostasis was achieved, and patient was transfused with 8 PRBC, 8 FFP, and 10 cryoprecipitate and shifted back to trauma ICU. Following this, the ICD output was serosanguinous with 150 ml, and BP was well maintained on vasopressors. This is the progression of the chest X-ray following thoracotomy, and the ICDs were gradually removed. However, on day of injury 54, patient had developed tachycardia and a episode of bleeding PR. A PR showed clots with formed stools, and proctoscopy was done, showed diffuse bleeding. So low molecular weight heparin was withheld. The patient had HB of 6.2 and 19 hematocrit, for which patient was resuscitated with blood and blood products. A CT angiography done had shown a bleed from the active contrast extravasation from the posterior wall of the rectum on arterial and venous face, for which a superselective middle rectal artery angioembolization was done. However, following this, patient had no further episodes of bleeding PR, but had developed respiratory distress. Patient had a pulse rate of 110 and a respiratory rate of 26, and a well score of 3 with a PF ratio of 265. So we had done a CTPA, which showed a partial filling subsegmental pulmonary embolism seen, for which we had restarted the low molecular weight heparin. There was gradual resolution of the respiratory distress, and patient was feeling better. However, following this, the patient had developed another episode of bleeding PR. However, he was not in any hemodynamic instability with the same diffuse bleeding with an HB of 7.8 and a hematocrit of 24. We had repeated a CT angiography. A repeat CT angiography done had showed previous coiling that was done, and the active contrast extravasation noted in the posterior wall of the rectum on arterial and venous face, for which a superselective middle rectal artery angioembolization was done again. Following this, a colonoscopy was done. This colonoscopy done showed a localized bleed in the posterior wall of the rectum. This was conservatively managed, and low molecular weight heparin was titrated accordingly. Following this, patient had no further episodes of bleeding PR. On day of injury 73, Patient underwent a decannulation of the tracheostomy, and patient had no respiratory distress following this decannulation. So this is basically the timeline of the patient during the hospital stay. He had arrived with a road traffic injury and had been diagnosed with a grade 5 splenic injury for which a splenectomy was done. Following this of day injury 5, an elective tracheostomy was done. Following this, patient had gone into multi-organ failure, which was managed as per ARDS lung protective strategy protocol. On day of injury 41, patient was operated for a VATS for a left retained hemothorax, and following this he had been re-explored for a bleed, and then he had the first episode of bleeding PR on day of injury 54, followed by a coil embolization, then had developed pulmonary embolism because the heparin was withheld. Following this, he had another bleed with a repeat coil embolization was done. And following this, on day of injury 73, decannulation of the tracheostomy was done. So the total transfusions during his hospital stay was 26 PRBCs, 25 FFPs, and 14 RDPs with the 10 cryoprecipitates that were transfused. The final outcome is the patient was successfully discharged on the home on the 3rd of December, the day of injury 75. His GCS was E4 V5 M6, ventilatory days was 44, and ICU days was 75. Coming to the discussion in this case. So in this case, our patient had a polytrauma with an high ISS score of 38, which was managed as per ATLS protocol. He had developed ventilator associated pneumonia and ARDS with multi-organ failure. He had developed complications from the central line. He had pulmonary embolism, a retained hemothorax, and a rectal bleed with a high geriatric trauma outcome score. Coming to the definition of acute respiratory distress syndrome in our patient who was intubated, the patient had a severe ARDS with a PaO2 FiO2 ratio of 100. What is basically this lung protective strategy? It is basically a low tidal volume, high PEEP, and proning. How does proning help? It reduces the pleural pressure gradient from non-dependent to dependent lung regions. It increases the end expiratory lung volume and improves the VQ mismatch and is considered for moderate to severe ARDS. Proning is basically done in 12 to 16-hour cycles. So in this study done in the New England Journal of Medicine showed that proning will lead to successful extubation and ventilator free days, which was statistically significant. This is a paper on the incidence of multi-organ failure in adult polytrauma patients. So since the 1990s, patients do develop multi-organ failure. There is no uniform definition of multi-organ failure. However, the incidence is around 20 to 30% of all polytrauma patients. As per the East Practice Management Guidelines, patients with hemothoraces should be considered for drainage. An initial attempt of drainage should be done with a tube thoracostomy. But however, if there is persistent retained hemothorax, it should be considered for early VATS. When it comes to the British Society of Gastroenterology guidelines, patients with major bleeds should be considered for a CT angiography, and if there is any active blush seen, the patient should undergo embolization. And in the same sitting, patients are recommended for colonoscopy following this. This is a paper on the geriatric mortality. For our patient, the score was 182, which was calculated by age, ISS, and if PAC cells were given within the first 24 hours. So the predicted mortality for this patient was 60%. So coming to the key learning points, if in early damage control, the patients with polytrauma require early damage control surgery, aggressive resuscitation, which can most of the time reverse extreme shock. ARDS is basically protocol driven and improves survival. Timely management of ICU complications is critical in making the patient survive, and polytrauma is basically a system outcome with multidisciplinary approach. To end, I would like to say that teamwork can lead to dream work. Thank you, and acknowledgements to the various departments that helped us during in the care of this patient.
Thank you, Dr. Saran. I request panelists for the comment. Amit sir.
First of all, compliments to the whole team, Teams Jodhpur and trauma team, along with their allied specialities who helped this particular patient come out of whatever complications he had from polytrauma. Before I actually start commenting, I would request Professor Russell Ewan, who is another expert with me, to comment upon this particular case, the salient features, and if he has any queries or questions for the treating team. Dr. Russell Ewan.
Thanks, Amit, and thanks, Dr. Saran, for a fascinating case. Certainly highlights how multidisciplinary and complex multi-trauma patients are and can be, and how so much intervention over such a long period can be required to save a patient's life. So the first question is, what was the outcome? You haven't told us whether the patient survived, what their physical outcome was, and particularly what their brain injury outcome was. So I'd be very interested in that information. The second thing, I'll go right back to the resuscitation, and I really want to comment on that more than the complexities of the later stage, because I think, as you know, the damage control approach and surgery is actually a damage control resuscitation approach, and we're trying to prevent death early on, but also trying to prevent all the complications. And I think it looks like you had a seriously injured patient arrive with obvious head, chest, abdomen, pelvis injuries. You diagnosed them quickly. You seem to manage them in a relatively timely fashion, although I note the patient's blood pressure became unstable in the early resuscitation phase. Their base deficit, you said, went from -3 to -8, and then they went to the operating theatre. So I'd be interested in how much delay there actually was in that early stage. And then I think my key question in the early resuscitation is about why wasn't a chest tube placed either in the emergency department or in the operating theatre before or after the splenectomy. And the one reason that I ask the question is prospective. I think when you're going to operate on somebody, you intubate them, give them positive pressure ventilation, you actually put them at risk with converting a pneumothorax into a tension pneumothorax. So I would be routinely putting a chest tube in if I was going to give them intubation positive pressure ventilation. Secondly, it seems to, the patient developed ARDS and then also developed a retained loculated hemothorax and presumably an infected collection, which is a big problem and could have killed the patient. And we don't know, but maybe it could have been prevented if the pleural space had been drained early on in the piece. So they're my two key questions. I'm going to leave it to the experts, though, like Subodh and Amit on management of complex chest injuries, to comment more about the management of that and the proning. Just to say, I've done proning in a few different centres. It's it's not something you enter into lightly. It's an enormous burden on the nursing staff. There's lots of complexity to it. You can easily dislodge tracheostomy tubes, lines, intercostal catheters, and everything doing it. While there might be benefit from a couple of reported trials, and certainly it's a salvage procedure for patients who have severe ARDS that's not responding to other things. I certainly urge caution in actually using it because of the complexities of it. Thank you. I'll pause there. Great case, really interesting.
Dr. Saran, there were a couple of questions asked by Dr. Russell. One is the resuscitation part, the chest tube part,
Yes, sir.
and obviously what was the functional outcome of the patient in terms of his neurological status when he was discharged, and in terms of the other, was the ambulatory, was the
Yes, sir.
so what was basically this functional status?
Thank you, sir, for the question. So coming to the first question, you had mentioned that during resuscitation, what was the time period? So he had the injury at 6 a.m. He had presented around 6:30 a.m. and he was in the OR by 8:15. That was the first thing. The second thing is the ICD. Yeah. So we had shifted to OR and placed the ICD in the OR prior to induction of anesthesia. Because he went into hypotension, so we had directly shifted to OR, and where everything was available, we had done it in the OR prior to induction of anesthesia.
Okay, my apologies. I couldn't see the tube on the early chest X-rays. That's why I asked the question. But thank you.
Coming to the outcome of the patient, the patient was ambulatory. He was able to speak. We had decannulated the tracheostomy. He was able to walk, and he was smiling. So he was quite happy with the outcome, and his GCS was fine. So I would say it was quite a good feeling to see him progress, and he had come in such a terrible state, and we had eventually resuscitated and did everything, and he is eventually walking and able to do everything now.
Thank you, Dr. Saran, for those clarifications, and once again, compliments. It's not every case of geriatric trauma who remains in the ICU for more than 2 months comes out smiling. It's very difficult. I must compliment your team for that. Yes, we do see a lot of geriatric trauma. We see a lot of prolonged ICU stays at the Apex Trauma Center in New Delhi also. Nearly 5 to 6 patients per month would land up in ICUs for more than a month, I would say. Some of them we've treated, and Dr. Subodh might correct me, remained in the ICU for in excess of 2 to 3 months. So yes, it does happen. And again, a word of caution, like Dr. Russell said, proning only to be done by very experienced people who actually do it on a regular basis, or the ICUs which do it on a regular basis. It is labor intensive, it is risky, it is only by professionals who actually do it pretty regularly. Chest trauma, again, you did the right things at the right time. I don't know the timelines, but as you diagnosed the retained hemotonics, you went ahead and did a VATS. As you found out that he was bleeding again, you went again inside again, and then probably tried to stop the bleeding from the intercostal arteries. I just wonder, I wanted to ask you, what might have been the cause for the bleeding from the rectum? Because it was diagnosed nearly about a month after, or it appeared nearly a month after his initial ICU stay. Was it initially a missed rectal injury, or what could have been the cause of his sudden rectal bleeding on the 31st or 40th day, I think?
Sir, looking back retrospectively, each CT angiography that was done, he had a loaded rectum. So probably that would have stretched or started causing the bleed in the rectal. It was a tear in the mucosa, which led to the bleeding. So probably retrospectively, that is one of the causes, because initially there was no rectal bleeding or no PR bleed. So maybe due to the prolonged ICU stay and his immobilization, he had developed this way.
Yeah, generally chronic ill patients or chronic ill in ICU patients do develop mucosal ulcerations, generally in the colon, but not that frequently in the rectum, but yes, he might have developed that. Dr. Madhur, I would like you to intervene and give your comments on the case, and if you have got any queries or clarifications in this regard. Dr.
Yes,
Madhur.
sir. Thank you, sir. An amazing case done. I must congratulate Dr. Saran that you just didn't manage this. The proof is in the pudding. The patient is alive. Whether you consider ARDS scores, whether you consider geriatric scores, or whether you consider any other score in this, whether you consider injury severity score, this patient had more than 50% chances to die. So most of the things were done right. I guess that's why the patient survives. But there are some nuances which I would like to discuss. Like Dr. Russell said, the ICD was placed. But why couldn't we place the ICD in the ED itself? Right? Decreased breath sounds, patient is going into CT, which are usually less equipped to place an ICD. So in our general practice, we place, if we have decreased breath sounds, EFAS is positive on the left, we put an ICD. Second thing which I want to say is that why was not early extubation done on 5th day when you opted for a tracheostomy? This patient had excellent vitals. This patient, he was maintaining an FiO2 of 30 with perfect ABGs. So why did we give the chance to develop a ventilator-associated pneumonia? Why did we not do an early extubation in this patient? So what kept us from extubating the patient on the 5th? Second thing, Dr. Saran, I would have loved to have data about the fluid management, because most of these ARDS patients have associated pulmonary edemas. You know, at least 25% of them have pulmonary hypertension. And in this case, they had, you know, BP is more than normal. So why did we keep the lung dry? You know, did we, was there a positive balance in the EFT day? It might be very well complicated by the fluid overload, right? So just wanted to know about the fluid management also. And early proning, Dr. Russell rightly pointed out, and Dr. Amit also, it should be done by a trained team. But in our experience, if done early, you know, like in ARDS, initial phases are exudative, and then the hyaline membrane forms. So if you do it in exudative phases, the clearance is much more faster. So why didn't we think of early proning before 13 days, so that if you're expecting ARDS, then was it an option for us? And then I want to comment upon indication of thoracotomy. This patient was doing perfectly all right. So you see, just there was some collection on the lower lobe of the lung. The rest of the lung is inflated. His ABGs are perfect. His gases are perfect, right? So a patient was on ventilator with so many comorbidities. Why did we choose to go? For example, okay, fine. I understand placing a chest tube would have been fine, but could have been done at a later stage when the patient was extubated, discharged, and then the thoracotomy or something could have been done. And was it not possible to, the outcome of the blood in thoracotomy was 200 ml, right? That is what you mentioned. So 200 ml is not a lot of blood, and neither did it derail the physiology of the patient. So just a YATS, which Yankur associated, you know, suction we could have done, we could have just put a Yankur, sucked out whatever came and then left the patient. Because this is a friable patient, this is an inflamed patient. And exactly things like intercostal bleeds happen in such kind of patients. So could we have postponed thoracotomy? And I'm certain the GI bleed part, I think your patient has all the criteria for the GI bleed. I mean, he had gone 2 times massive transfusions, right? So ischemic colitis is very likely in such kind of patients. Moreover, this patient had an acute kidney injury. So uremic toxins, they cause platelet dysfunctions. So majorly, and this guy is an old guy, right? 60 years old, might be having atherosclerotic components and all those things also. So my colitis, to me, it occurs ischemic colitis, might be a cause which needs to be seen. But I commend your team. I mean, I've never seen them pinpoint a loaded colon with bleeding and pinpoint the vessel of the injury, and radiology which showed us exactly where it was bleeding. So with these questions, I would like your inputs, Dr. Saran.
Dr. Madhur, I will clarify about a lot of things because I don't know, Saran, we were aware about these point of or no. The early extubation patient having the severe head injury. Although initially he was the M6 and veritable, but later on he became the M1, M2. So CCS was a bit concerns. 2-3 times was CT was done. Neurosurgeon was on board. So there was the dilemma ki craniotomy to be done or not to be done. Although it was not fit in the criteria of craniotomy, decompressive craniotomy for the head injury. So he was the low GCS. That's why he keep the intubated for a long time. Once it's gone 5th, 6th, 8 days, he develops some pneumonia or the VAP acid things are there. And so that's why he was not early extubated. This was the one indication. For the ICD in the ER, as Dr. Russell also asked the question, he was stable. So we thought we go with the, although we can put it, it can be put it. There's no problem. There's no hard and fast we should not do. We can do it. But patient was stable. So we get the, and he was the irritable one. We thought there was a head injury because there's an if you see the case from the initial one, there were anisocoria was there. So we thought there's a head injury was there. So we pushed the CT earlier and we go to the investigation. For this, that ICD was not placed at that time. For the indication of the for fluid one, yes, fluid restrictive therapy was started and it was a strict intake output was the managed. But where and then the patient developed the septicemia. That's why there's the idea ARDS and the whole things. For the indication of thoracotomy, yes, it was the because the patient was not the straightforward case. That's why we could not go directly with the VATS and the thoracotomy. Initially, it was the put the ICD one, but patient was in sepsis. Sepsis, we thought this is the source of sepsis. That's why we land up on the thoracotomy. The VATS one, the OR procedure for the chest one. We delayed because we thought this is not right case. As your intention, this was not the green case. It was a very hot case, old age and multiple core. So we should delay it. We thought we should delay it, but this was the one possibility. The team decided this. Team thought this is the cause of the sepsis one because there's a retained hemothorax. It might infect it because the ICD was there. Initially, the ICD was there. So that's why we decided the thoracotomy, not thoracotomy. We started at VATS. It was converted to thoracotomy. These are the few other concerns you raise. These are the explain. I'll not say explanation, but these are the reasoning of these things. I hope you get the.
Yes, sir. So now we know the reasons behind, sir. It makes it much simpler and clearer. Just have few doubts, sir. On 5th, we did a tracheostomy for this patient, right?
Yeah.
So, and his GCS was 5.
Yeah.
On 5th. So, did we continue with the intubation because now the low GCS is not an indication for keeping the patient intubated because we did the tracheostomy on 5th. So, did we were the say efforts not good so that we prolonged the intubation of this patient?
In initial phase, it was the low GCS till the till the tracheostomy. After that, it developed the VAP, and we could not extubate because the PF ratio and saturation, the whole ventilatory setting could not allow to extubate that. This was the reason of the prolonged intubation. So this was things, and few couple questions are in the chat box. Can we take? There's one question. I will ask the Amit sir better with the right person to answer. What is the indication of true ICD after the thoracotomy? Amit sir. Doctor.
Generally, we would not put 2 ICDs unless there is an air leak or we suspect that there is a massive hemothorax, or we are suspecting that we might land up into a retained hemothorax. On here, we can clearly see, even despite putting 2 test tubes, the patient did have retained hemothorax and the complications thereafter. We would generally put it only when the air leak is there and we cannot manage that. Then in most of the cases, we would just put in 1 chest tube in the initial dose. After thoracotomy, at times, or after decortication, we do put 2 chest tubes because primarily after decortication, there is some amount of air leak and we want to get rid of that air as early as possible. I think that is the reason, that those are the indications of two treats, otherwise generally we put only one treat.
There is one question from Dr. 𝘱𝘰𝘭𝘺𝘵𝘪𝘰𝘳𝑚. I'll ask Dr. Madhu, what alternative to the proning do we have event of the persistent soak in ARDS? Because proning is the one strategy, the ARDS one, but if there is a severe soak, proning can't be done in that case. So what are the alternative of proning in the ARDS?
Sir, a good chest physiotherapy, good physiotherapy of the lungs, N-acetylcysteine, the basics. Proning helps to, when we prone the patient, the weight is lifted off the heart and all those things, and it gives an excellent outcome in ARDS patients. But sir, then to our experience, it is all in the basics. Regular physiotherapies, vibrations, steam inhalations, N-acetylcysteine, mucolytics, and maintaining the sepsis all this while, sir. That nothing, I guess, is beats those simple basic strategies.
So I will say the prevention is better than cure. So start early chest physiotherapy, the right things. Okay, thank you. There is one thing Dr. Ramesh asked, in such cases when you will consider the post-splenectomy vaccination. Dr. Russell, what's your experience or what do you say?
For post-splenectomy vaccination, I think the conventional approach that we still take is to delay after an emergency splenectomy the vaccination for 7 days or so. I'm not sure that we have good evidence still about the relative merits of early versus delayed vaccination. I think still post-splenectomy sepsis is such an uncommon outcome that we are, any sort of longitudinal cohort study or trial is unlikely to give us more information. And I think there is sometimes a risk that people forget. So that's the argument we use for giving it early, just to make sure that, before the patients that go home and someone says, oops, did we give the vaccination? Oh, we did. Oh, we forgot, and you lose that patient. So I'd almost be okay giving it on the operating table. I don't think it matters too much otherwise. Yeah.
So literature also say at the time of discharge, vaccination should be done. This is the post-splenectomy vaccination. There is one more question, and any specific protocol for post-ICU rehabilitation, especially in such geriatric patients?
I think most of the protocols would be general rehab protocols. I do not think that there is any specific protocol for rehabilitation after prolonged ICU care. But in general, obviously, you look at various systems, right from the CNS to the respiratory system to the psychomotor issues to ambulatory issues. And it has to be a comprehensive rehab team, not only focusing on the chest, but I think mobility, especially because this patient also had head injury, to go ahead and do some sort of a neuropsychological evaluation of finer cognitive functions. So it has to be a comprehensive physical rehab team coming together. And in the centers in the West, where I have seen such midway homes, as they call it in the US, not discharging directly to the home, but keeping these patients in rehab centers, which have inpatient facilities, is, I think, an ideal thing, which is still a far thought in a country like India. But we do have rehab centers with inpatient facilities. I think we need to strengthen them more, and we need to look at rehab now. Now that we have started saving lives, the next thing would be a lot of focus needs to go on the rehab in the whole systems paradigm of trauma care.
Sir, the interesting question is asked, was ROTAM or TAC was used? This is for us, but what is the take on the ROTAM and TAC in such cases?
Just before we go to that question, can I just follow up Amit's response to the question about rehabilitation? Because I think any trauma patient, rehabilitation is important. Remember, the role of a trauma system is to do life-saving care at the scene, provide timely treatment of injuries, and then restore function and independence. And we mustn't forget that last third of the three major tasks for the system. Any patient that's got physical injuries will take some time post-discharge to get back to their normal health. And it's remarkable when you follow trauma patients over weeks and months, how long it actually does take to get back to physical health, mental health, return to work, return to school, and so on. Much longer than most people originally appreciated. The Victorian State Trauma System now routinely follows patients out to 5 years at least, we've got data from, through telephone interviews, structured, standardized questions administered by nurses with that data along quality of life scales, EQ5D, functional outcomes, health service use, and so on. And it's very clear that for major trauma patients, you have to go out 2 years to be confident that people have reached a steady state, right? 1 year is not enough. 6 months is definitely not enough. And I think the lessons in that for us are that the end of our responsibilities don't finish when the patient is discharged from hospital. And what happens after is obviously very contextually dependent. You know, US can send, Australia too, can send people to rehab centres and have a insurance system that pays for them forever. But most places in the world can't do that. Amit and Mahesh Mishra and Subodh and I, with the AITSC, piloted a randomized trial of a home-based rehabilitation intervention a few years ago, where we actually wanted to train family to do at least simple physical rehabilitation for lower limb injuries. Now, this patient's a much more complex one than that, but we're at least trying to think through how could you do at least some rehab. And I'd urge everybody on this call to give that some more thought, because this guy will have lost so much body weight. He will have lost so much muscle mass. There's no way he would have been able to walk out of hospital, I suspect. So what the question is, what do you do afterwards? And now your other question was about Rodha. I'll let somebody else answer that.
Yeah. Thank you, Russell, for those insights into rehab. And you're right that we need to look beyond the discharge. We need to look beyond anything, because now that people are surviving trauma, major trauma, in India, we need to look at how they fare 1 year, 2 years or more after the discharge.
Sir, I was asking about the road time and the tag in such cases, because we started 3-4 times the MTP one. What's the
No.
So my take on that would be we use the viscoelastic assays very commonly. I mean, those are the routine things nowadays at level 1 trauma centers. If you have facilities, I think you need to look at ROTEM and I think there's some disturbance there. Anyway, so yes, they should be used liberally. They would save a lot of blood and blood products instead of giving 111 or 112. If you goal direct that the blood therapy through viscoelastic acids, they are pretty useful. Very.
What is the role of the DLT? Is the DLT mandatory for the VATS and for cortisol?
I think I'll let Subodh answer that. It's not mandatory, but I think Dr. Subodh can answer that.
I think very good morning and very good morning, Russell. I think the DLT is not mandatory. It depends on the indications, right? If you are doing a emergency thoracotomy, anterolateral thoracotomy, you don't have time. It depends on your intent. So DLT is reserved for elective thoracotomies or VATS, and because you want to achieve a single lung anesthesia. And as an alternative to DLT, nowadays they are putting the bronchial blocker, right? So, but these are the things which are luxury and reserved for elective VATS or thoracotomy. So this is a very, very simple. And I think if we are running out of time, if no more pressing questions, then Ramesh, would you like to There is one question in the chat box that are the participants would get the e-certificate for the CME. We have not started, but yes, definitely it's a good idea. And from in future CMEs, we can think of giving the CMEs to the participants if they will register for the CMEs. Any all the panelists and the any last word from the panelist and the moderator before we.
Just want
Yes.
to let
Yeah.
know, Dr. Russell rightly said that rehab is contextual. So though India is very primitive in rehabilitation centers and everything, but we have a ray of hope. That is the strength of the family. The family structure is very strong in India, and usually we underestimate it. So if we tell the family about rehabilitation strategies, we train them, I think that would go a long way, rather than waiting for those expensive centers to come up. So, my takes.
Definitely. Right, that's right. Any last word, Professor Amit?
No, I think a wonderful case presentation, a lot of takeaways from it, both in terms of clinical judgments, in terms of treatment, in terms of ICU care, and also at the end, a thought about rehabilitation of these patients who have prolonged hospital stays.
I agree
I think
completely.
with that,
yeah.
Yeah.
Russell, final words?
Well, thank you. Look, what a great privilege it is to join all of you. And congratulations to ISTAC for running this sort of forum. It's a great forum, great case, great people, great discussion. I look forward to joining again. Thank you for involving me.
Thank you. And we'll be needing you in future CMEs as well as an expert.
Great to see Russell.
Sir,
this
good morning,
morning.
sir.
I think Mahaveer, what I would request you to audit it, that could you have done like on the basis of the questions asked differently to reduce ventilator days, to reduce hospital stay, ICU stay. I think when Madhur asked those questions, I think that is what in the audit we must be doing. Yes, we do compliment for such a complex trauma patient where the presentation was very variable, and this kind of a GI bleed. Russell, I don't know how many times you have encountered this, but I think it's extremely unusual for rectum getting ischemic and there is ulcer which bleeds. And to your credit or to your interventional radiologist credit that he could angioembolize twice in the same hospital stay, and you successfully overcame this problem, which was naturally you would think that as soon as you think of discharging a patient and patient comes up with this kind of a issue, what was coming to my mind, maybe a liver or hemophilia was causing this GI bleed, but the rectal ulcer bleeding and you could manage, and there was no rectal perforation actually. So that was something was very, very eye-opening and extremely unusual to witness this kind of complication. But credit goes to the whole multidisciplinary team at AIIMS Jodhpur to have successfully bringing out this 60-year-old gentleman. We do talk of young trauma patients coming out of such complex and complications and prolonged ICU stay, prolonged hospital stay. And we have seen, even despite our hard work for long periods, many of such patients do not make it. But this is, and I agree with Russell, what in AITSC we did have a component of what basically social media use of rehabilitation. And that is something which we initiated at trauma center, and that can be used extensively, Madhur, even with you in AIIMS Rishikesh, that your people can get in touch or the patients can call if they are having this problem. We had a call center in the beginning of trauma center, which I'm not sure whether it is continuing, but that can help a great deal for these patients, because as Russell said, that it is extremely important for these patients to come to full functionality. And it does take time with so much going on in the ICU. So again, congratulations, Mahaveer. Saran, you presented extremely, extremely well, and compliment to you. Congratulations to you. Very well managed, very well presented, and congratulations to one and all. Thank you.
Thank you, sir, for
Thank
the
you,
kind
sir.
words. We'll get back to the stack and you also about the quality improvement to retrospective analysis, what happened, what we can improve.
The idea of audit is just, could we have done something differently? That was the idea. Maybe nothing could be done differently what this patient underwent, but idea is, could we have done something? Although when Saran said that it is 60% probability of his, there is 60% mortality. That's what you said, Saran?
Yes, sir.
Yes, sir. Yes, sir.
So I think that is itself, it speaks that all your scores were unfavorable, but still this patient made it. So unusual survivor, I would say, this patient was, and congratulations.
Thank you, sir. Thank you, panelists. Thank you, sir.
Thank you, Mahaveer.
Sir,
Thank you,
next
Mahaveer and team. Yeah. Would you like to announce, Ramesh, the next month
yes, sir.
webinar? Yeah, Supreet.
Hello.
Yeah, please. Yeah. Veda, yeah. Please.
Yes. Good morning, everyone. Next session of TAC Grand Rounds will be held on Feb 22nd, that is last Sunday of February, 10 a.m. to 11 a.m. The case is about the rectal foreign bodies. The AIIMS BHU from Banaras will be presenting the spectrum of autoerotic rectal foreign bodies. We'll release the meeting details shortly. Thank you.
Thank you very much. Veda.
Thank you.
Any other announcement, Ramesh?
No, sir, nothing for this time.
Thank you all very much, and enjoy the Sunday. Thank you very much.
Thank you, sir. Thank you.
Bye-bye.
Bye.
Thank you.
Bye.